Okay, for our next presentation, Dr. Barrett will be speaking, giving us an update on the clinical approach to spatial neglect. Dr. Barrett is the program director of the neurorehabilitation program at Emory University. She completed her medical training at the New York University School of Medicine and her residency at New York Presbyterian Hospital. She completed her fellowship at the University of Florida at Gainesville and is board certified in brain injury medicine, neurology, behavioral neurology, and neuropsychiatry. Welcome, Dr. Barrett.
Well, it's really exciting and wonderful to be with you all. And I am just really honored. I want to thank Dr. Dresser and my friend and colleague, Eleanor Pollock, for nominating me today. We're going to change gears a little bit. I really want to echo, though, how exciting this time is for stroke care. And, how it's just so wonderful for me to see how different things are in terms of the very systematic and the very urgent care of patients, and the very high priority care of stroke patients. And now I think in this talk and in the next talk, we're going to talk about what happens after the first 72 hours or so, and some of the approaches to disability, because actually in many of the studies that were done on acute stroke treatment that led to some of the wonderful systems that we have now, there was rehabilitation that entered the scene on day one. And so I want to try to give you all some tools to try to think about that for the right brain disorder, spatial neglect. And as of today, or actually tomorrow, I'm in Massachusetts, so you see my Massachusetts affiliations. Just one moment. Okay, so these are my disclosures, and I'm going to just reference that the talk title comes from an article that at the end of the talk, you'll see my email, and you all will be able to, if you wish, go ahead and email me, and I'll be happy to send you a copy, one of my private copies of the paper, so that you can read more if you're interested. And I just really am not just representing myself. I'm representing all of my collaborators, all of the stakeholders, people who've taken part in research studies, both in my lab and in others, and a number of different federal funders. Anybody who's a taxpayer has contributed to my research, so really want to thank you. So we're going to talk about spatial neglect, and it is a disorder that's one of the most common disabling problems after stroke. People usually think about, for example, when they think about the things that we want to avoid after stroke, they think about paralysis, they think about aphasia. But actually, in a study that was done and published in the Lancet in the 90s, spatial neglect was suggested to be much more toxic in terms of being a barrier to independence. And on the upper left here is Roy Horn, who until he passed, unfortunately, during the COVID pandemic, was the most famous person with chronic spatial neglect. And we're going to talk about kind of some of the signs that he's evidencing here of spatial neglect, and what that has to do with animal research, and then potentially some treatment approaches. But the definition of spatial neglect is pathologic bias, so toward one space. Usually we talk about left or right space, and it has to cause functional disability. So I said it was one of the most common, and I don't expect you just to kind of believe me. We have at Emory a comprehensive stroke center, and we also have within the hospital partnerships a number of primary stroke centers and stroke-ready systems. And in the comprehensive stroke center at the Emory University Hospital, and Fadi Nahab and David Loring are kind of the senior people who've worked with me on this, but a number of other great folks, and Jessica Salmon, Sabrina Nachbickel, Karima Benamer, and Jens Convoy-Hellman, who did the actual testing, helped us to do some screening for disabling problems after stroke that are in the realm of cognition, because this is an area, as I said, that people kind of usually leave behind, and oftentimes there's really needs in this area. So when we think about this pathologic spatial bias, how can we assess for it? And we'll talk more about this later, but what Janice did basically at the bedside, people who had strokes even a few hours before, is just classified using this a method, which is kind of like an NIH stroke scale of spatial neglect, And about half of people, which is quite consistent with other studies, have signs of spatial neglect. So, Karima, who's a hospitalist, and Fadi said to me as we were beginning this initiative, boy, it's surprising to me that so many people have this problem. However, I, having worked mainly in post-acute settings, and seeing many people after they are discharged from acute stroke setting, was not surprised, because really the literature indicates, and so this is a number of different studies from the 1970s to the present, about half of people with right brain stroke, but then about a third of people with left brain stroke also have the signs of spatial neglect. And that really, I think that the tendency to underestimate that kind of has a sweet relationship with what we've been hearing about stroke, because in the past, right, we used to use our intuition. I was taught that 99% of what you need to take care of a patient you'll get by just going into the room and talking to them for 5 minutes. But clearly, we have to do the aspect score. We have to look at their perfusion. We also need to formally assess disabling problems such as cognitive problems, because unfortunately, as was mentioned, not just in terms of right brain stroke, but in most cognitive problems, people are not themselves aware and able to report their cognitive issues. So actually this study, Kimberly Reha's study in 2017, it was done in very chronic stroke patients with left brain stroke and aphasia, and out of 40 of them, 5 of them had signs of spatial neglect that had not been identified by their caregivers. So we're going to take a look. We'll have like a little break for humor here. So what does spatial neglect?
Dr. Barrett, I'm not sure if it has volume, but we're not hearing anything. You may have to, when you share your screen, you may have to select that box.
That's exactly right. You're right. Let's go out and let's stop the share. And let's go back in. Sorry, this is going to show my age. I apologize for that. So share sound. Thank you for the reminder. I was wondering whether I should stop. Come on. Yep, there.
Yep, now we're good. Thank you.
Where the hell did I put this?
What are you looking for?
The remote. The remote. I can't find the remote. Did I lost? I lost it. Did you take it? Did you put it someplace?
No.
All right, what is this?
What is what?
All right, very funny. I get it.
You're in a weird mood.
Come on. Go back to your apartment and fix it.
Fix what?
Your pants!
What's this? I got one pant leg on for.
Don't you know? Hey, look at your face. You only shaved the right side of your face. What is this, a joke?
No, joke? What, a joke? You think this is funny?
So look at your face in the mirror. Yeah?
It's George.
Come on up. You mean you didn't know you were doing any of these things?
Oh, I swear.
I'll bet this is from that kick from that crazy Joe Davola. You better see a doctor and get some x-rays.
X-rays.
You were telling me just a few minutes ago about how you had suddenly had a headache at home and how you called 911. Remind me again, what were the symptoms that you had at that time? What was it that was wrong?
Well, I was sort of confused in my head as to what was happening around me, and just didn't seem to be able to function good.
So didn't feel all right.
Right. And my husband is very hard of hearing. And I think I tried to tell him what was happening, but I don't think he quite understood. So that's why I called 911.
Were you weak anywhere in your body at that time?
I don't think so, because I remember I got up and I think I sat on a step or something. I remember sort of sitting on a step.
So the left side of your body didn't have any weakness at the time?
At
when
that
you first-
time, no.
No.
Okay, and what about when you came to the hospital? Were you weak anywhere in your body?
Not that I remember of.
Any visual problems that you had at first or in the hospital? None at all. Okay. I'm going to check a couple things, and I want you to look at my nose, and just Buffer, you can make sure that both of my hands are visible.
Okay.
You look at my nose, and can you see something wiggling now?
Yes,
Good. And what did you see wiggling?
his fingers
Good.
to
And
the
show.
right,
Good. Correct. And now, how about now?
his fingers to the left,
Good. How about now?
to the right,
Now.
to the right.
Now, actually, those last two times, I was actually wiggling fingers on both sides.
Oh, yeah.
Okay, so I'm going to do that sometimes. I'm a little bit tricky. I'm a little tricky that way.
Okay.
So I want you to watch out for that, okay?
Okay.
Where am I wiggling the fingers now?
To my right,
Now.
to my left,
Now.
to my right.
Okay. Okay. Now, actually, that last time I was wiggling fingers on both sides.
Were you really?
Are you having any trouble with your vision, do you think, on the left side?
Not that I know of.
Still doesn't.
Okay. I'd like you to lift up your hands for me like this. Good. And you can open your eyes. That's very, very good. Can you close your eyes actually one more time? Keep them closed. Good. Keep them closed now. Okay, go ahead and open your eyes. Anything different than it was when you closed your eyes?
I don't think so. Do you
No?
have glasses on?
I did actually before. I took them off on the videotape. You're a smart one. Well, like most people, I'm a little bit vain about wearing my glasses on videotape. There's actually something else that I did that changing about my appearance. Did you notice anything else different?
No.
Okay. I actually took my jacket off of one side. Can you see that it's off on my right side?
Yes.
Okay, good. All right, thanks. You can
You're
stop.
tricky.
So she has spatial neglect, and she has a sign called extinction to double simultaneous stimulation. It's not a visual problem because she can see when I hold up my hands, she can see the one on the left side when she's when it's by itself. But when there's two, she's not able to. And you can imagine that's very disabling if you're trying to drive, or even if you're just doing dishes, or if you were, doing laundry. People will tell me that they can't, that they've left the faucet on the left side of the hot water, unfortunately. Or, people have had driving accidents. And unfortunately, people like the patient we just saw who have difficulty not with seeing, but with perception or awareness, have been misdiagnosed. And sometimes people would say a person like her doesn't have any problem at all. Other times, if this problem is more severe, it gets misdiagnosed as delirium or motivation problems or depression or intellectual issues. And not to say that people with spatial neglect can't have these other problems, they often do. However, it's like aphasia, a separate and distinct problem because the spatial system is its own cognitive domain. All right, and that's probably a big public health issue because basically, because misattribution of these symptoms is the rule rather than the exception, diagnosis of right brain stroke is generally not sufficient. And we see that when we look at clinical trials, large clinical trials. And when we look at kind of general care of people with right brain stroke, because right middle cerebral artery stroke patients are oftentimes not evaluated in as timely a manner. Again, they may be less aware of their symptoms. However, even if people around them are aware of symptoms, sometimes they are dismissed as having been, signs of chronic problems like mentioned. And we were talking about awareness. That is definitely an aspect of spatial neglect. So we see over here on the right side of the slide a test that's on it's a real simple test, really simple test you can do on just a piece of printer paper. You can just mark these. Back in Indiana, where I grew up, we used to call them chicken scratches. So you can put these chicken scratches all over the paper and ask the patient to cross them out. And this is called the Albert test because Martin Albert from Boston was the first to use it. And frequently, people with spatial neglect after right brain stroke will have difficulty crossing the ones on the left, and they'll say that they're done after they've crossed the ones on the right, as here. And again, this was the task that was used in the Lancet study that we talked about in the 1990s. It showed that diagnosing spatial neglect was a better predictor of loss of independence than hemiparesis or aphasia. But we see other things, those of us who study medicine or psychology oftentimes see these kind of things in textbooks where someone is copying the star and they miss the left side, or they kind of draw part of the cube, but they're not drawing the whole thing or part of the flower. And in doing something simple in the kind of that's not really very realistic, not very reflective of everyday functions, such as marking the center of a line, that's a very sensitive test of the function of the right brain, because the right brain is dominant. I hate when people call it the left. They talk about the dominant hemisphere because it depends on what function you're talking about, what's dominant. The right brain is dominant for spatial computations. And so if we ask somebody to judge the middle of something, somebody with a right brain stroke will almost always go to the right. And healthy people usually go to the left. If I had been able, I wish I had been able to come there in person this year, but I would have probably passed around the line and asked you all who were there in person to mark, because most people will mark to the left of center, although not very much. And people are unaware of their symptoms, and you have to actually test. But it's not just unawareness. But let's look at some examples of this unawareness so we have a sense of what we're actually looking for.
Do anything yet,
Okay.
but I'm just putting a paper napkin over here, mouthwash, and your comb, okay?
Yep, anything wet?
Yes,
Okay.
just give me a second.
You see the video moving?
There's water in here,
Okay.
so I want you to use the paper
We
towel.
can hear it, but
on the
it's
table.
stalled.
Sorry.
No?
I need to go out and come back in again. Sorry.
There's a paper towel on the table. To your left.
So I apologize that that wasn't as clear as I would have liked, but the person who's very alert and very responsive and asks and wears the paper towel that I need, I'm going to wash my face and to wipe my face with, is unable until she's cued to find something on the side. You can see her penny passes, and many people, just like her, come to, for example, therapy settings and are never treated for this problem with awareness or with stimulus detection.
Do anything.
It's not just unawareness that people might have. They may also make other kinds of errors because of this difficulty of perception.
Okay, how many people are in this room?
1, 2, there's 3 people.
Okay, who's here?
You, me, and animated objects.
Animated objects?
Yeah, like the pictures, the calendar, books.
Are they people?
No,
No. Okay, so how many people are in this room?
3. You.
1, 2.
3.
Where's the third person?
1, 2, 3.
Can you touch the third person?
Yes.
Okay, what's that person's name?
Angelique.
And how do you know Angelique?
She's my daughter.
Can you point to her hand?
Excuse me. As I am right there. Well, I guess you can't see it.
Where is it? Okay. Show me where it is. Where's Angelique's hand? Okay. You ready to head back upstairs?
Yes. What now?
Okay, how many people are in this room?
So essentially you can have, when you have a problem with perception and not vision, things will fill in and people can have difficulties with things that perceiving things that are not there. It's not delirium, although delirium is more common in spatial neglect, as are kind of other cognitive issues. But a key sign I think we all know about is unawareness, but it's not the same as a visual field cut, right? Because that is visual loss. So people wouldn't be able to see a single stimulus. And then a number of other differences between blindness or visual hemianopia and spatial neglect. And we can see this extinction. We can also see errors of commission, where people think things are over there in the bad side that are not really there. And unfortunately, people can again attribute, and I've seen people like the person that we just saw who had a right brain stroke, and she did have some difficulties with memory and thinking, but people thought that she had kind of enough delirium that she would not be able, for example, to return home. Whereas that, perhaps was not the case given her overall level of daily life function. So what I'm going to kind of allude to is that in understanding the subtypes and the symptoms of signs of spatial neglect, we can think about kind of cognition as being something that happens in stages. And that's a classic way of talking about cognition. Sometimes people talk about cognition like it's kind of a global concept, like attention or concentration or something, but I'm not talking about that. I'm talking about the classical model of what's cognitive. And basically, that model allows us to think about different stages that might take different systems, might be critical for them. So frontal lobe systems versus parietal and temporal lobe systems, for example. And we're not going to talk today about other kinds of theories like health psychology or exercise or kind of public health or personality theory. Though not to say those are not important, but this is kind of a neuropsychological theory that goes with the stages. And so we have stages coming in, and this is what we've been talking about here, is stuff coming into the system perhaps being abnormal when people have spatial neglect, but there's also stuff that comes out of the system that can be abnormal. And we're going to talk a little bit about that. So basically, in all kinds of animals, people are oftentimes not aware that there are animal models for spatial neglect that go across the mammalian class. So almost any mammal can be induced to have spatial neglect. And these are pictures of, mice and rats with spatial neglect after brain lesions. And they're usually subcortical, but can also be cortical models. And interestingly, it's a dopaminergic model. So a lot of people even now are doing research relevant to Parkinson's disease and producing this spatial neglect syndrome as a component of the animal's behavior. But it is potentially not just a sensory issue, rather it's a motor preference issue. So these animals rotate. And we can see that with dopaminergic systems in a number of different studies in both animals and in humans. But again, we didn't go through all the cat and dog and other animal research that's been done. But people as well have been shown who have spatial neglect have been shown potentially to improve when dopaminergic systems are manipulated. So what does it look like when people have this motor output problem? And I'm going to hope that we can take a look.
Push yourself out. Good. Where are we heading? Okay. What way do we have to turn? Okay.
Yes.
Where do we go now?
Okay.
Where is your bed?
Was to the left there.
Yeah?
Where's your head? It was to the left.
Go to the bed.
Yeah. All right, I'm going to back you up so you can help me steer.
So she just keeps going forward. Right, so she knew where her bed was. She said it was to the left. Yet you see her eyes and her head and her movements consistently biased to the right. So it meets the definition of spatial neglect. It's pathological spatial bias causing functional disability. And the impression people oftentimes get when they look at this behavior is that the person is impulsive, perseverative, or that they have a kind of overall trouble understanding instruction. But in fact, this person understood the instruction and she gives verbally the correct instruction, but she's not able to make the correct movements in response to it. So let's look at another example. Basically, by the way, never do this. Never have someone using a rolling chair in any of your medical encounters, whether it's a caregiver or a patient, because in one of my organizations where I was in the past, that was the only place where a fall occurred in a clinic was when a caregiver was using a stool. But we see this, I think all of you have probably seen this behavior in people with stroke. And I know I've heard people of all kinds of different medical disciplines talk about this as a sign of stroke. It's basically a very cardinal sign, a very key sign of aiming or output spatial neglect. So this is one of the few articles where pictures of this sign were shown. So this is my colleague in physical therapy at Emory, Laura J. Cox. She's going to ask this person who's had a right brain stroke and has spatial neglect to get up, and he's learned the technique. If you have a hemiparesis and you're lying on the paralyzed side, you lean forward and utilize your good arm to push yourself up. All right, so you have to make a rotation in the direction of in the contralesional direction. So in the direction, in his case, of his spatial neglect. Now watch what happens instead. He knows he's supposed to put his hand there, but he doesn't make any leftward rotation. Instead, he rotates to the right, and he makes a 180 like this, right there. Yeah, let's switch that just one more. See if we can. There you go. Oh, here we go. So he's trying to go just physically incapable. His spatial neglect affects his aiming systems, his motor spatial neglect, and it only allows him. He's not able to. This does not have any paralysis. This is spatial neglect. Oops. So here's another cardinal sign of spatial neglect that is a motoric sign. Basically, none of you are here, so I have to be careful because oftentimes if I do this demonstration, I'm among medical professionals, so I'd be safe. But basically, putting on eyeglasses is a sign that is a function that doesn't require vision. So spatial neglect is not only a visual problem; it can be, as we were talking about, a motoric problem. And if we put on glasses, we utilize, yes, a representation of the body, but we also utilize an arc of movement. And that brings the glasses to my face. Yay, I didn't need any medical intervention for safety. However, if we're not able to do it accurately, what can happen if we make a movement that's too small and we try to compensate by moving our head into the glasses is that we'll end up with glasses over the ear. And this is what we see here in this article that my colleague in Alabama wrote on spatial neglect, the hanging eyeglasses. And I've had colleagues in the field of stroke who've recognized this in the emergency room, able to diagnose spatial neglect in the emergency room. So these are some of the components of aiming spatial neglect. Basically, the brain has not allocated the same motor resources to one side, to moving in one side of space as moving to the other side of space. So we can have basically hypokinesia, we call it, to one direction in one side of space and depicting one limb. And it always is separate from just paralysis. So let's watch it again.
You can put those on. You're welcome.
There's no no, she's very kind.
You gonna put them on?
Right, so again, this lack of ability to move leftward. So she basically holding the glasses in her right hand and moving her head. Always do signs in spatial neglect until proven otherwise. So we see the sign again here. I don't have time to tell the whole story of what happened in New York, Israel, but essentially it can even produce problems turning to the left in a car or truck. So there was a truck driver whose only sign of spatial neglect was that he couldn't make left turns in the emergency room in New York, Israel, and he had a subcortical stroke. So we see the similarity, right, of this postural, and we all would recognize this postural abnormality. It's just a shame that it is not kind of captured on typical testing, because it not only is important to kind of initial function and falls, for example. So here's people with neglect of the Kessler system and without neglect. Almost all the people in a 2-year period who fell had spatial neglect in that particular group that was published quite a while ago now. And this is in rehab, so that's accounts for the long stays. But even though they stayed longer, people with spatial neglect were more likely to end up going to skilled nursing care after acute rehab, which is problematic. Right? And again, quite a few people with spatial neglect, more of them, as you might expect, in the inpatient rehab setting or post-acute setting than they would be in the comprehensive stroke center setting. And my colleague Muyana Park, who is the CMO now at Burke Rehab in Westchester, New York, showed that in people who had spatial neglect in the days following stroke, 6 months later, they're less likely to have good community mobility than people with similar severity of stroke. So it's not just a sensory or perceptual disorder. Really, literally, it can be a motor disorder. And the signs include the difficulty moving to the left, difficulty moving on the left side, this is after right brain stroke, and difficulty with moving the left limb. But you can see these signs on the right side as well after left brain stroke. And unfortunately, I have, even at lectures like this one, heard people, very experienced clinicians, say, oh no, this is not neglect, this is just hemiparesis. However, it's very obvious, for example, when we look at the way that that person was trying to sit up, that there's more going on than just hemiparesis. And unfortunately, I think that results in this supposition that spatial neglect is kind of an uncommon problem and just an awareness problem. And again, we have to look formally at and we have to assess people if we're going to do treatment. And I'll talk at the very end in the last 2 minutes or so about treatment. But be assured that it's not just me kind of urging you potentially to identify spatial neglect, but a number of professional organizations, including the American Heart Association, the Occupational Therapy Association, a number of British and Canadian stroke associations. And again, if you want the article that Kevin Houston and I wrote, I'll be happy to send it to you. I also did a continuum for the American Academy of Neurology that reviews those professional guidelines. And the problem is that people oftentimes kind of send someone off for neuropsychological testing. That's great, but paper and pencil testing doesn't tell you really how people are going to do in real life, except if you use this test called the Behavioral Inattention Test, and nobody really uses it, unfortunately. It does have the ability to predict daily life function. You have to do those studies, right, in order to prove. And oftentimes in neuropsychology, that's not the way that studies, the paper and pencil tests are standardized. Instead, there's kind of a test that occupational therapists can learn to use. And it's like an NIH stroke scale for neglect. And we know, I think, in the area of stroke care, how much care was revolutionized by having a common language for the severity of stroke, and to start talking about the NIH stroke scale and have all the practitioners from the emergency, clinicians to the nurses to, people who are doing rehabilitation work to people doing cognitive work to the stroke staff, all doing the NIH stroke scale. Well, in the same way, this test can capture things like what we're seeing here, which is not usually captured right in the paper and pencil test. You're not going to write down what the person was looking at the right side all the time. So this is the scale, and I can teach a therapist, an occupational therapist, to administer this. I've also taught, physicians, nurses, other speech language pathologists, physical therapists to administer this scale. But it's probably most appropriate for occupational therapy in most settings. And these first three items are the ones we were talking about at the beginning when we talked about spatial neglect happening in about half of patients after stroke. So this captures what we were just talking about before, and it's distinct, right, from what we are looking at in the NIH stroke scale, although it may be complementary, because this is not, related to, for example, haunting lesion that would cause gaze paralysis for other reasons. So now we're going to talk for a couple minutes about the reason for identifying people with spatial neglect. And that is that most people with spatial neglect, I think it's probably about 8 out of 10 of people with spatial neglect are not diagnosed, and so they can't be treated. However, the other 2 to 4 people are diagnosed, but unfortunately evidence-based treatments are not usually used. And prism adaptation therapy is the treatment that I have really emphasized, because there's kind of a recipe for it that's really easy to administer. So I mentioned that I could train people to identify spatial neglect. It's much easier to teach them to treat spatial neglect. I can teach most people, I can teach probably anybody in 2 to 4 hours how to treat spatial neglect, even in complex cases. And all you need to do is use off-the-shelf wedge prisms, optical wedge prisms, and it's a treatment that you would do for 2 weeks, ideally, over 10 days, but people have used what are called distributed methods too, as rarely as once a week or 2 to 3 times a week. And it's improved activities of daily living in randomized controlled trials. So it doesn't just improve kind of laboratory stuff or biological stuff. It improves people's ability to get dressed, people's ability to walk, people's ability, and I've seen this with my own eyes. It's a powerful treatment, and it can be billed as part of regular inpatient and outpatient therapy. And because it can be trained easily, it's less labor intensive. Most of the other approaches, for example, cueing approaches or visual scanning approaches, require a lot of training. It's like cognitive behavioral therapy or behavioral. So let me tell you a little bit about how prism adaptation therapy works. Basically, what we want to do is put on these wedge prisms, optical wedge prisms, and this is what the wedge looks like. So it shifts what the person sees toward the direction, if we think of those as an arrow toward that direction. So what they see something directly in front of them and they try to touch it, they're going to go too far to the right. And what you want is to put on these goggles, and they put them on for about 20 minutes, and they try to touch something. In our protocol that we've utilized at Kessler Foundation and other places, we have them do a task in different parts of space with a kit. And what we find is that afterwards, their aiming or their rotatory tendency to the left, if they have a right-way stroke, is improved. So we can see this after effect. And that is an improvement of directional kinesia of aiming spatial neglect. But also you can see that they move the left arm more and that they can rotate the trunk. And a silly example is that, you know, in the early stages of doing research in this area, in like 2003, 2004, I had a person who was taking part in the research, and he was coming out of the research room, and I was standing on the left side, and he turned toward me for the first time after 2 treatments. He turned toward me and he goes, "Hey, see you later, doctor." So it's visible. It's actually visible. Unlike other treatments for spatial neglect, which it's kind of like aspirin. You kind of have to take it, on good faith. So, for example, here's a sign of spatial neglect. People have difficulty knowing where the center of their body is. And that's where it says that the center of the body is, right? It's too far off to the right. Again, not a visual problem, but a spatial problem. After one session of prism adaptation, so that's making movements while wearing prism goggles, he makes an error to the left. And you might say to me, well, is that really better? We've improved the directional kinesia. And what we have to do is kind of say, well, we have a number of randomized controlled trials now, more than 20, that show that this kind of a change can benefit people's ability to do things in real life. And this slide is just here to tell you that the aiming spatial neglect form responds. So this is reduced spatial neglect, is the line going down. It responds particularly well. But other forms of spatial neglect, people sometimes say to me, well, you know, regular spatial neglect will go away spontaneously. But here, over 7 weeks, you see that people who had perceptual problems really didn't improve at all. And interestingly, the responders had larger brain lesions. So these are the responders on top, and this is the right side of the brain here and the left side. So you can kind of just see that these heat maps are larger in responders, and they included the frontal lobes. So that was just a very interesting thing, that aiming spatial neglect may be particularly responsive. And we want to think about, I think, in general for our care of patients, that a patient-centered approach, which we think about, for example, for aphasia, as was mentioned, can also be used for spatial neglect, and it might result in personalized treatment if we think about aiming. And really think about referral to occupational therapists who are familiar with spatial neglect, and in particular, if they're familiar with prism adaptation treatment. So this is my email now. I'm an adjunct now in the Department of Neurology at Emory, so you can actually reach me at either email, but this will be faster. And again, if anyone wants to get copies of the article that this talk is partly based on, be happy to share it or, have further discussion and questions offline.
Thank you, Dr. Barrett.
I'm just wondering what percentage of people you see that have spatial neglect also have cognitive deficits?
Well, again, spatial neglect is a cognitive deficit. So by definition, if somebody has spatial neglect, and then, you could, by the DSM definition, call that vascular dementia because it's a cognitive deficit. However, if you're referring to, for example, memory problems, they quite commonly co-occur. Again, think about, though, the reasons for that. If you have something that happens in 50 to 80% of people, it's going to be very commonly co-occurring, right, with other disorders. So is that just a statistical co-occurrence, or is it, a problem that, is linked? Are the networks linked? And people have made good theoretical arguments, right, that the hippocampus, which is an important memory area, it was meant to be a spatial memory area as well. So in animals, for example, it's used for caching, for, squirrels to find their nuts, that they've buried. So wouldn't be surprising if spatial neglect and memory disorder co-occur. Certainly people with spatial neglect have memory disorder very frequently. Although it's interesting that sometimes you can kind of demonstrate that their memory disorder has spatial properties. So for example, there was a guy named Bisiak in Italy who had people try to remember a famous place in Italy, in Milan, a piazza, a plaza. And when they imagined standing on one side, they couldn't remember what was on. These are people with right brain stroke and left neglect. They couldn't remember what was on the left side, but then he asked them in their minds to walk to the other side and look. And suddenly they remembered everything that what was now on their right side, but they couldn't remember what was on the left side. So it may not be a pure memory disorder.
Thank you, Dr. Barrett. Could you comment a bit more on auditory spatial neglect and what this might look like?
Oh, this is a really good question. And I first have to say that there's not a lot known about the functional consequences of auditory spatial neglect. So in this talk, I've really tried to emphasize some of the pragmatic problems that people might have, because that's part of the definition, right, of spatial neglect. However, auditory spatial neglect basically means that you can hear, but you can't you're spatially biased. So, for example, if somebody has good normal hearing and they don't have cerumen in either ears, or, if they have relatively normal hearing for their age, they may have a tendency to be able, with their eyes closed, to identify a single stimulus, but they may not be able to identify two stimuli. So if I snap my fingers on both sides, they may not be able to identify the left side of one if there's one on the right side, but if it's by itself, they can identify it. A problem with doing this is there's not good kind of bedside stimuli, so you'd have to have kind of like one of those clickers, because I, as a strongly right-handed person, I can snap a lot more loudly with my right hand than with my left hand, and I hate, I don't mind in some contexts kind of looking like a magician. That's kind of a cognitive neurologist thing. But I mean, I really hate doing this because people think I'm like not doing something silly rather than doing something that's important to the patient. So if you're going to test it at the bedside, you should switch. If you're like me, strongly handed to one side and make a louder one on one side, you should switch. And you should do it behind the patient. But auditory inattention is one of the items on the 3-item CBS. And what we very commonly see is that somebody won't just have trouble on the contralateral side of space, but they have trouble with auditory detection anywhere. And obviously, it seems to me, or in kind of research talk, by face validity, that would seem to affect safety in a number of different ways. However, there's not enough studies. And in particular, for example, I've been curious about that for driving, because I think most of us know that there's kind of this American tendency to want to be really insulated from the outside world, and that reduces auditory input that can make for safe driving habits if we hear, a siren, if we hear a horn. There's the other thing that's kind of interesting, that if there are people in the audience who either have a loved one with spatial neglect and stroke, or who have a lot of patients with this problem, is that frequently with auditory things is where we see the spatial neglect in terms of wrong way behaviors. So if somebody's talking to somebody with spatial neglect, on the other side, you know, they may spatially mislocalize the stimulus and they may respond to the other side. And, you know, I always say that if we have this phenomenon of someone in the emergency room responding across the curtain, for example, to another doctor, that person almost always has a right-sided lesion, and they always have some symptoms of spatial neglect or a right frontal, oftentimes a right frontal or subcortical injury.